if you're pregnant, having a baby, planning to get ready and build a family, or you've had a pregnancy that didn't go your way, this is the episode that's going to be for you. I'm your host, Benj Faiman, and today on the Patient in the Room podcast, I'm sitting down with one of Australia's most respected obstetricians and maternal-fetal medicine specialists. He's delivered thousands of babies, performed surgeries inside the womb, and pioneered a new way for mothers to actually reach down and lift their own babies into the world during a Caesarean. He's based in Melbourne, one of the most reviewed specialists on Doctify Australia, and has a near-perfect rating from his patients. Dr. Stephen Cole, welcome to the podcast.
Thank you, Benj. Those very nice words too.
The nice words are even nicer from your patients. Very excited to have you on. I did mention that you're one of the most highly rated doctors on Doctify, and I think it'd be great to start with what one of your patients actually wrote about you. They said, "We truly believe we would not have had our precious daughter if it weren't for Steve and the exceptional team that he has built." That's not a review, that's a letter of gratitude. Does it ever hit different reading things like that?
It's very humbling to hear those things, right? It's this is a job that I do and that I absolutely love, and that I always try and, do my best for my patients, not only in a physical sense, but also in an emotional, supportive sense. And when you get that sort of feedback, it does make you think, yeah, you know what, I'm happy I've done a good job for her. Yeah.
Fantastic. So it's really good to hear that it's always, patient first, patient focused. I think that's what we love to see. And, as patients, what we love to feel, that we're being put first by our doctors and our specialists. Before we dive in, for anyone who hasn't actually heard the term maternal-fetal medicine specialist, in plain English, what does that actually mean, and how is that different to an obstetrician?
Yeah, so I guess first and foremost, I trained as an obstetrician gynaecologist, and the Royal Australian and New Zealand College of Obstetricians and Gynaecologists has a 6-year training program, and at the end of that, you come out qualified as a general obstetrician and general gynaecologist. And then I chose to specialise further into maternal-fetal medicine, which is very much the realm of complicated pregnancies. So there's additional training. There's another 3 years of supervised training, and there's research and exams and a whole lot of boxes that you need to tick. There's training in genetics, there's training in clinical obstetrics, there's training in research methodology, and training in ultrasound as well. So most maternal-fetal medicine specialists spend most of their time looking after more complicated pregnancies, and we can talk about what a complicated pregnancy might be, but also performing ultrasounds and really using evidence and state-of-the-art medicine and evidence to guide patient decision-making.
Cool, incredible. So obviously you're going into genetics there, you're going into sort of the whole person at a cellular level. Does that mean the studies that you apply, that you learnt, you're now applying to your patients, and you're pretty much from the start of your interactions with them, you're going to the root cause of whatever that complexity might be, or to kind of prevent any further complications?
So a lot of it's really understanding the sort of the underlying pathology and the underlying physiology in a way that's perhaps at a deeper level than a general obstetrician would do. And I think that gives you insight to understand disease processes more, and that can help you make decisions about timing of delivery, for instance, or what level of supervision of a pregnancy is required. So sometimes that allows you to say, look, I think this pregnancy needs more supervision for various reasons, but sometimes it actually means you have the confidence to say, do you know what, this is not as high risk as you thought it was, or that you were worried about, and we can actually back off a little bit because we have the confidence to know that this is not a situation you need to be as concerned about.
I can imagine as a patient hearing that, you'd be able to relax a little bit. Do your patients enjoy hearing this and getting that reassurance from you?
I hope so. I think so. I think a lot of people have, in the community, I think there's a really simplistic understanding of risk when it comes to pregnancy. So there's this sense of you're low-risk pregnancy or you're a high-risk pregnancy. And of course, risk is not a dichotomous thing. It's not a binary thing. It's a slope, right? And so there are people who have slightly more risk than a completely low-risk pregnancy, and then the risk goes up with each kind of gradation. And sometimes the risk relates to things that can go wrong during the pregnancy. Sometimes you've got no concerns about the pregnancy, but the risk relates to birth or to the things that might happen after birth. Okay. And so what I try and do, I guess, is to not say you're a high-risk pregnancy or whatever, but to actually say what are the things about your pregnancy that carry additional risk, and then how are we going to handle those specific things. Mm-hmm. So rather than labelling someone as a high-risk pregnancy, I try very hard not to do that because I don't think it's good for people to feel about themselves that way. Mm-hmm. Just to talk about what are the things that make their pregnancy more challenging or things that we need to be more careful about.
Yeah.
And then focus on those things.
Normalising the risks that anyone could potentially be exposed to.
Correct. And normalising the bits that can be normal, right? So even people who have very high-risk pregnancies still want to be able to enjoy their pregnancy
100%.
and get excited about it and feel relaxed about parts of it at least. And I think where you can normalise part of the pregnancy or part of the journey, then it's really important to do that.
That's incredible. Again, coming back to patients first, making sure they can enjoy this experience is an incredible way to go about things. I know you don't want to label them as high-risk pregnancy patients, but what might a high-risk what actually makes a pregnancy high risk is the question.
So again, as I said, there's different types of risks. So risk related to events during the pregnancy versus things that might make the birth itself more high risk or the actual delivery. So things that make a pregnancy high risk through the pregnancy itself are things like having underlying medical diseases. So someone who might have an underlying heart valve condition or a different type of cardiac condition. We're seeing more and more women now who are getting pregnant having had congenital heart disease themselves. So they were born as babies with heart disease and they're now getting to childbearing age. And because cardiology care and cardiac surgery has improved so much over the years, many of those women are now at an age and at a level of health that wouldn't have been possible in the past. So that's an example, I guess, of someone who might have significant risk attached to the antenatal course of their pregnancy.
Fantastic. And obviously it's a bit of a spectrum, but let's say stick with this example. Someone who is considered high risk, they can have a completely smooth and healthy birth and pregnancy and birth as well. Is that possible?
Absolutely. And in fact, most of the time that is what happens. So even people who come into pregnancy in a very high risk situation, most of the times actually have a good outcome. We have a healthy mother and a healthy baby at the end. And that journey might take a few twists and turns. Mm-hmm. So they might have to spend some time in hospital. They might need medication or other surveillance or intervention. And we might end up with a birth that's a bit more premature than would be ideal. But ultimately, thanks to, I guess, the massive leaps that we've made in newborn care, neonatology, that even with premature birth these days, most of the time, the outcome is still very, very good. So even people who are very fearful of pregnancy because of what they've been told about the level of risk, most of the time will be able to get through that pregnancy and have a healthy outcome.
Okay. And I guess that plays into that supervision aspect that you mentioned previously. I guess going to hospital is one level of supervision. What might be another example of a bit more supervision during a pregnancy? Because I guess we can understand what less would be.
Yeah.
So what would more be as another
example?
example?
It might be more frequent visits.
Okay.
It might be more ultrasounds looking at placental function and baby's growth. It might be, we do something called CTG monitoring, which is fetal heart rate monitoring. And fetal heart rate monitoring might need to be done more often in a higher risk pregnancy. It might be additional blood tests, for instance, if we're worried about deteriorating kidney function or liver function. So you want to monitor those sorts of things more closely. So they're the sorts of things that are individualised, really to the patient.
Sounds like a lot of different things to really personalise the experience, and no pregnancy is going to be the same, nor should it be, but everyone has many options to make sure it's a comfortable and a safe experience for both them and their child.
So no pregnancy is the same, but no person is the same, right?
Correct.
And so people bring with them into pregnancy different fears, different emotions, different things that they're excited about. And so it's about trying to create an environment for everyone where their needs, be they physical or emotional, are met during the pregnancy.
Mm-hmm. I'm glad you touched on the emotional side, because I know a lot of the comments that we get on Doctify about, the whole experience they've had with you, a lot of it dives into the team that you've got.
Mm.
Can we just dive into, I guess, their roles and I guess how they support you and your patients, because they're a very, very important part of your practice?
Yeah. So I guess I had this vision for what I wanted from my private practice, and that vision was very much to build an environment. I often talk about the journey to motherhood rather than just having a pregnancy, right? And so that's trying to help women feel supported through the whole pathway from pre-pregnancy through to even after the baby's born. We don't stop when the baby's born, okay? So we try and create an environment where people feel like we're their second family for the duration of their pregnancy. So they know that they can call the rooms, and my front desk staff will basically say anything you need, we'll work it out for you. Okay, that people can just say, here's my problem, and they know that we're going to try and fix it.
Mm-hmm.
I have 3 midwives that work with me, one of whom's a lactation consultant as well.
Wow.
And we work collaboratively. So they'll see patients in a scheduled way. We have some scheduled appointments during the pregnancy, which are around education and getting things organised for what might lie ahead, getting ready for birth, for instance. We have a breastfeeding preparation appointment specifically, so teaching people how to breastfeed. And those midwives are also available to answer questions anytime. Patients will ring or patients will email. And sometimes it's just a matter of reassurance, a quick come in and hear the baby's heartbeat because they're freaking out.
Mm-hmm.
Other times it's answering very specific questions. And then we also have a home visit built into our pregnancy care package. So after mum's given birth and spends a few days in hospital, and when she goes home, that's a time when all of a sudden all of the support that was there in the first few days after birth suddenly disappears, right? And she's on her own. So we have a visit roughly about a week after a patient goes home, where one of my midwives will come to your home. Incredible. And sit with you for an hour or two and work through whether that's feeding difficulties, or you're struggling to settle your baby, or you're concerned that there's a bit of jaundice, or you're just feeling like it's all really hard work. They're there to support you through that. And whilst we have that one visit built in for everybody, sometimes people need more than one visit, and so we have ongoing contact with them.
I think that's a really, really valuable thing for patients to hear, that the experience goes beyond the birthing experience. It's when you get home, and I think it shows that your whole team see the value in the support when they need it as well, and that can come at any moment. We're going to shift the conversation a little bit now, because I know there's a lot of Australian women that are navigating this. It's the rise in IVF pregnancies. You have a large number of patients who are coming to you through their IVF journey. So does IVF change the pregnancy from a clinical standpoint? And, are there things that you should watch for differently going through IVF?
Yeah, so that's a good question, because it is an increasing component of obstetrics, is patients coming through that IVF pathway. And there are a lot of misconceptions around that as well. So it's true that as a cohort of women, people having IVF tend on average to be older, tend to have other medical problems that may make their pregnancy higher risk. But not everyone who has IVF has a high-risk pregnancy. Unfortunately, a lot of them are led to believe that because they're having IVF that it is a high-risk pregnancy, and they come into pregnancy very anxious. And often that's on a background, of course, of trying for a while, dealing with disappointments, having maybe a miscarriage or two, having cycles, IVF cycles that don't work, and so there's the expectation and then the deflation of emotion. And so people do come into pregnancy after a period of IVF, often feeling already like the deck is stacked against them.
Does that change in, I guess, emotional well-being influence the potential success rate or the pregnancy?
So I don't think we've got a lot of really good evidence around that. There are many, many stressful life events that women and couples have to deal with that have got nothing to do with IVF or nothing to do with their pregnancy. And we don't have a lot of evidence that says that those sorts of life stresses necessarily change the outcome of a pregnancy.
Yeah, it'd be hard to isolate that in a...
Yeah, there's a little bit more evidence, I think, around how those stresses might impact on your ability to get pregnant in the first place. But once you're pregnant, not so much. So we have people that have, very high-pressure jobs. unfortunately have people dealing with, for instance, domestic violence
Yeah.
or, loss of a family member, trying to juggle 3 or 4 kids and, manage a household and all of those, really stressful things. And I guess it's, I think, good to remind people that those things don't translate to worse pregnancy outcomes in a general sense.
Yeah, and I guess bringing that back to the services that you and your team are providing, it shows that you guys are aware that this might be something that can be difficult and an extra stress on their mind, and that you guys offer that support to say, let us help you get through this so that we can have an overall incredible journey together, which is a really nice way to bring it all together. Some other risks that I know we hear about pretty commonly is gestational diabetes. Is that as serious as people fear, and how is it managed?
Yeah. So I think it's a good question, because I think gestational diabetes is an example of a condition or a circumstance that's kind of over-dramatized in terms of the impact that it might have on a pregnancy. So it's very true to say that people who come into pregnancy with pre-existing diabetes, long-standing diabetes, often bring with them significant health problems associated with that long-standing diabetes, and those pregnancies are very, very high-risk pregnancies.
Mm-hmm.
And they do require the sorts of things we were talking about before, with closer supervision both of mums, because diabetic control and keeping sugar levels normal can be really difficult in pregnancy. But also in terms of significant fetal risks, risks for babies in the womb in terms of placenta not working well and things like that. So we do have a higher level of surveillance for those pregnancies. But gestational diabetes is a very different kettle of fish, right? So gestational diabetes is someone who had no or very minimal insulin resistance problems before they got pregnant, but the hormones produced by the placenta increase insulin resistance as a normal physiological thing. So every single woman has more insulin resistance during pregnancy than before she was pregnant. But for a proportion of those, it goes a little bit too far, and that's when we label people as having gestational diabetes.
Okay.
And the main issues with gestational diabetes are things like babies being overgrown because they're getting exposed to too much sugar in the womb. And that can make them, of course, difficult to deliver. So there's higher Caesarean section rates, but there's also higher rates of maternal perineal trauma, for instance, tears and episiotomies and instrumental deliveries and those sorts of things. But the other thing is that babies that have been used to very high sugar levels set their own hormones at a level to cope with that. And then all of a sudden, they're removed from that sugar fix, if you like, by cutting the umbilical cord, and so they're not getting that high level of sugar anymore, but they've still got their high hormone levels, and that takes a little while to wind down. So babies are at risk of hypoglycemia or low blood sugar in the hours after they're born if they've been born to a mother who has gestational diabetes. Because we give people that label, though, we know that those are babies we have to watch. And all of the hospitals have protocols around monitoring baby blood sugars in the hours after birth when they're born to mums who have gestational diabetes.
Mm-hmm.
So we know from research that when we take those steps and when we monitor those blood sugars, those babies are at no more risk of a bad outcome than any other baby. But that's because we're doing that monitoring, okay?
I think that's the reassurance that patients really want to hear, that the monitoring is there and that reassurance, and there's protocols that every hospital is following here, which is really, really important to make sure that when they hear that this is something, it's not an additional stress that they have to really focus on, but they can understand the protocols that are set up. And I guess that's your job there, to reassure them of that.
Well, that's exactly right. And, there's a lot of noise in the community around pregnancy care, right? It's a very big topic on social media and just amongst friends and family. And, we often look to our mums and grandmas and their pregnancy experience. And, of course, a lot of that information that's out there is not perfectly informed, okay? And there is a tendency, I think, to over-stress the importance of gestational diabetes in the community. So, when I'm seeing someone who's got a label of gestational diabetes or a diagnosis of gestational diabetes, the first thing I'm trying to do is normalise things. Yeah. Make sure they understand the difference between gestational diabetes and pre-existing diabetes, because often those two things get meshed together in people's minds. and they're worried about risk of stillbirth and all of those sorts of things. And so we need to de-escalate some of that in that initial conversation.
Incredible. I'm glad that, there are patients that are going to the right place to get that information. They're guided towards what's really needed for them. Another common issue and something that I know that you've dealt with, something I know a lot of people are going to become more aware of. Spoiler alert, if you haven't watched season 2 of The Pit, just a warning. I did see it. It's an episode on preeclampsia. It's something that you manage. Can you tell us a bit more about what it is, why it matters, and what are the warning signs that someone should not ignore?
Yeah. So preeclampsia is common, right? So about 5%, 1 in 20 of first pregnancies will develop preeclampsia.
Wow.
So it's reasonably common. Most of them are mild cases, so right at the end of pregnancy and relatively easy to manage. But a proportion of them are more complicated and they're more serious because they happen much earlier, or the degree of preeclampsia is much worse, okay? We have some strategies to mitigate and manage preeclampsia, but ultimately the only cure for preeclampsia is delivery of a baby. Wow. And then a woman will start to get better. And the great thing is preeclampsia always resolves. You're not left with preeclampsia after the pregnancy is finished, but it can take a few weeks for things to settle down sometimes. So if we have someone with very severe preeclampsia where we're starting to worry about maternal safety or baby safety, then delivery is the option, right? And if that happens to be at a premature gestation, then these are really big decisions that have to be made. But luckily, most preeclampsia isn't like that, okay? Most preeclampsia is milder, and towards the end, where delivery is usually not consequential for a baby. In terms of warning signs, it can be very difficult to self-diagnose preeclampsia until it's very, very late in the course and until it's very, very severe. We do worry always about people who complain of persistent headache, particularly headache that's unrelieved by simple measures like Panadol and rest and hydration and those sorts of things. People might get significant edema or swelling. The problem with that is every single pregnant woman effectively gets some degree of swelling, and only a very small proportion of those will have preeclampsia. Yeah. And
correct me if I'm wrong, is it pitting edema that they don't want? Is that the symptom?
Even then, most pregnant women by the end of their pregnancy will have pitting edema.
Okay.
But I guess if you notice a sudden change in that, so over not multiple weeks, but maybe over a few days, you notice your edema become significantly worse, or particularly if you notice increasing facial edema, which is less common. So most people will get edema of their legs and their ankles and feet and of their hands and things like that. But facial edema, particularly when it's significant, is a bit more likely to be related to preeclampsia.
Okay, good to know. I think these are the valuable little nuggets of information that people can take home and sort of sit with, which is great. Moving on to, I guess, something that's a bit more joyful, which is twins. Yes. I know it's something that you deal with quite a lot. You actually previously led the multiple birth clinic at the Royal Women's Hospital, a role that you held for several years. These are also on the rise, largely because of IVF. What's the first thing that you tell a patient when you tell them that they're having twins?
So first of all, I tell them that I had twins, and that always makes them feel a little better. Because I think people are worried about their pregnancy, but they're also worried about how am I going to cope with having twins after they're born. And, everyone knows that it's, hard work, right? Having a new baby is tough, and having 2 new babies at the same time is challenging, right? So I always try and reassure people first of all. But what we talk about depends very much on the type of twins. So twins that have separate placentas are called dichorionic twins. And not all, but most dichorionic twins are what we call fraternal twins or non-identical twins. And the risks for those pregnancies are not twin-specific risks. So I do talk to people about the fact that almost anything that's risky in a pregnancy is a bit more common or a bit riskier in a twin pregnancy compared to a single pregnancy, including just the physical discomforts. People are much bigger towards the end of their pregnancy. So everything is more challenging with a twin pregnancy. But the overriding thing that's important, I think, is the risk of preterm birth. Okay, so in Australia, we define preterm birth as less than 37 weeks. But when we talk about a due date, the due date is 40 weeks. So the last 3 weeks of pregnancy is considered term. And anything less than 37 weeks is considered preterm. Now, in a singleton pregnancy, about 7 or 8%, so a bit less than 1 in 10 babies is born preterm. And luckily, most of those are born late preterm where the consequences are not so severe. But in a twin pregnancy with fraternal twins, about 60% of them are born preterm. Again, most of those are born late preterm where the consequences are not super important, but where it's still problematic because babies are in a nursery and so you don't get the cuddling, bonding, feeding experience that everyone's kind of hoping for. But a proportion of those are born at very early preterm birth gestations, and the consequences of being born really early are much more severe. Okay, so that's dichorionic twins or fraternal twins that have separate placentas. Then we talk about monochorionic twins or twins that share a single placenta, and they're a riskier group of twins because that sharing of a placenta is an inherently unstable environment. So twins that share a placenta are effectively always identical twins. They come from a single egg and a single sperm to get together, and then a split occurs after conception. And those twins, in addition to all of the issues related to non-identical twins or twins that have separate placentas, mainly around prematurity and all those pregnancy complications, there are some specific problems related to sharing a placenta. And we talk about conditions called twin-to-twin transfusion syndrome and selective growth restriction as two important things where those pregnancies can be impacted. And so the risk for preterm birth and the risk for adverse outcomes is significantly increased in those twins.
Let's talk about the twin-to-twin transfusion syndrome. What is it and what can actually be done about it?
Yeah. So because twins share a placenta, their circulations are not separated. So when two umbilical cords come in, one from each twin, into the placenta, but blood vessels actually course between the babies. So if you were in theory to inject a dye into one baby, into its circulation, you'd see it come out in the other baby, a minute or two later.
Wow.
So there's constant sharing of blood in all monochorionic twins or single placenta twins, okay? And that's normal, right? But a proportion of them, about 10%, will develop this problem of twin-to-twin transfusion syndrome, which is where that sharing is unequal. So the amount of blood going in one direction from one baby to the other is different to the amount of blood coming back. And that may be because there's more arteries going in one direction than are coming back the other way, or it may be that the vessels that are going from one baby to the other are larger than the vessels coming back to that same baby. So over time, there's this net imbalance where blood is gradually shifted from one baby to the other. And so in that situation, we see that one baby has not enough blood and the other has too much. And what that translates to is babies behaving the same way we do when we are dry, under-volumed, or when we've got too much fluid on board. So if you've been out all day walking in the sun and you're dehydrated because you haven't been hydrating well, you don't go to the toilet very often, right? If you have sat there and drank, 6 litres of Coke, you're going to go to the toilet every 10 minutes. So one baby is not peeing out enough urine, and the other baby is peeing out far too much. And the amniotic fluid that's around babies in the womb is mainly urine. So babies are living in their own urine, which is a concept that always makes people smile, but we all did it. And so over time, those differences become greater and greater and greater. And historically, twin-to-twin transfusion was a devastating complication. And in fact, before we had effective treatments, the mortality rate, the death rate for babies in established twin-to-twin transfusion was about 90%.
Wow.
It was terrible. Okay. We now have some therapies and they've been transformative in terms of those survival statistics, but it's still a very dangerous condition and a risky condition, and the outcomes are still not always good.
Do we have a percentage or an approximate percentage of what the mortality rate's like now with twin-to-twin transfusion?
Yeah, so if you have twin-to-twin transfusion, so again, like everything in medicine and certainly in obstetrics, there are degrees of severity.
Of course.
But if you have anything beyond the most basic or simplest form of twin-to-twin transfusion, with treatment, about 2/3 of pregnancies both babies will survive.
Wow.
Okay.
It's a big difference per.
Yeah, that's right. But it's still 1/3 of pregnancies with twin-to-twin, no babies will survive, right? And so that's still a very devastating condition. We know that about 85% of pregnancies, at least one of the babies will survive.
Yeah.
So most women, most families will get to take home either one or two babies with twin-to-twin transfusion now, whereas in the past, most families got to take home no babies.
Yeah. It's a fantastic turnaround, and I guess it's great to see that the research is still going towards that. What does proper care look like from the mother and the father side of that when, they do have access to it in Australia?
Yeah, so again, very much around surveillance. A lot of what we do in pregnancy care is around surveillance, looking for problems, anticipating problems. So once you've been diagnosed with a single placenta pregnancy, monochorionic twins, you will go into a program usually of surveillance starting at about 16 or 17 weeks in the pregnancy, so quite early, and then a scan at least every fortnight to look for the evolving disconnect between too much fluid in one baby and not enough fluid in the other. And that will continue all the way through to the end of the pregnancy. Okay. And of course, 90% of the time we don't see those problems, and those women have lots of scans and lots of visits and lots of very nice, pleasant conversations, but no real stresses.
Yeah.
But when we start to see twin-to-twin transfusion developing, then we need to, first of all, increase the level of surveillance because we're trying to gauge how quickly things are evolving. And then we're thinking about, well, what sort of treatments might be possible, okay? And the treatments depend on things like how quickly it evolves, but they also depend on how far through the pregnancy you are because the treatments, which effectively these days usually mean surgery in the womb, are not completely benign. They're not completely risk-free. And so what we do in this condition and what obstetricians do really with every pregnancy all the time is think about what are the risks of the babies staying in the womb or having treatment in the womb versus what are the risks of them coming out. And the risks of babies being born, of course, change very much based on how many weeks through the pregnancy you are. So if you're 24 weeks, the risks of coming out are substantial to babies. They don't all survive, and some of them will survive with problems like cerebral palsy from being born far too early. Whereas if you're 34 weeks, the risks of coming out are not quite zero, but they're negligible in comparison to 24 weeks. So what we then have to do is think about, well, how many weeks are we in this pregnancy? How likely is this surgery to be successful? And some of that relates to the position of the placenta and the health of the babies. And then if we decide not to do the surgery but take them out instead, what are the risks if they come out?
Okay.
And those are very difficult complications, and they can be difficult at an intellectual level just to do the maths of the different potential scenarios.
Yeah.
But then, of course, there's the emotional overlay for parents as well.
Of course.
We're talking about not an intellectual concept. We're talking about two babies for them, right? We're talking about their family. And so navigating that is something that's really tricky and requires lots of conversation, lots of compassion, lots of understanding, but lots of clarity also in being able to express those different options clearly and in a way that parents can understand.
Yeah. Just diving into the surgery in the womb aspect, I know this is something that is, incredible to even think about. This is something that you've done.
Yes.
Can you give us maybe a story, if possible, of what that might be for a family?
Yeah. So in terms of what a mother goes through, once we've made a decision that surgery is going to be the option that we're going to recommend for her, and once she's agreed that that's what she wants to do, the surgery itself is usually done in an operating theatre, but under local anaesthetic, so patients don't usually go to sleep. It's done using ultrasound to guide us, and we put a telescope, make a little cut, only about half a centimetre or so incision into the skin.
Wow.
And then we pass a telescope through that incision, which goes straight down into the womb. And so we can actually visualise in the womb. We can see the babies moving around. You can see the little hands waving and things like that. But what we're interested in looking at is the placenta. And what we're trying to do is map the vessels on the placenta and work out which vessels come from one placenta, from one baby and go across to the other baby, versus which vessels come out to the placenta, get rid of the waste products, get oxygen, and go back to the same baby. Because it's those vessels that are crossing from one side to the other that are the ones that we wanted to fix. And then once we've identified those vessels through our little operating channel in that telescope, we can pass a laser fibre, and we use that laser fibre to obliterate those connecting vessels.
Wow.
And then the babies usually self-heal after that.
Incredible.
So they start to normalise. One starts to produce the urine that it wasn't producing before, the other one backs off a bit, and the amniotic fluid level drops off. And that's the perfect outcome, right? If you see that normalisation and 2 healthy babies the next day when you look. That's
incredible. My jaws literally dropped hearing that. It's crazy that this is something that you've done. I'm just mind blown. It's incredible work, and I think it's really reassuring again for families here that these are things that can be dealt with, even in the more complex cases. That there's options to give them a chance to have 2 safe babies being born. I want to move the topic across to something that's a bit more difficult to speak about. It's because it's quite personal and people don't talk about it enough. I am talking about miscarriages. I think the first thing that we need to do is acknowledge that they are more common than people believe. I believe it's around 1 in 5 pregnancies end in a miscarriage in Australia, mostly, early stages. But I think we should dive into this, and I want to hear from you, I guess, what's a really important aspect when, dealing with a family who's unfortunately experienced a miscarriage.
So I think you're right. It's a difficult topic. And it's a topic that we don't talk about enough. I'm really pleased that that's actually starting to change, and it's being led by the College of Obstetricians and Gynaecologists, but it's also being led by lots of patient groups and community groups as well. And I think individual people are getting more confident to start to talk about these things. And I often say to people, if you're brave enough to tell someone that you've had a miscarriage, or tell your friends and family that you've had a miscarriage, you'll be blown away by how many of them say to you, well, I've had one of those too, or I've had a couple of miscarriages, and you had no idea because no one talked about it. Okay, so I do think that being able to talk about it is really important, right? It is common, as you said, about 1 out of every 5 or 6 pregnancies ends in a miscarriage, but that depends a little bit on the age of the mother. So miscarriage is more common as women get older. So if you're 20-ish and having a baby, your miscarriage rate is probably closer to 1 in 10. If you're 40-ish and having a baby, it's closer to 1 in 3 or 4. Okay,
1 in 10 though, that's still pretty
it's still
common.
pretty high.
I
Absolutely.
think that's what we need to stress here. That getting pregnant on its own, it's a difficult experience, and then taking those first steps, especially the first trimester when you're at high risk of one, is also a difficult thing to get through. I know there's this theory or a belief from experiences that people currently silently is something that they've done wrong. How do we fight that? Because we know it's not something that they have done wrong. Yeah. But how do we deal with that?
Yeah. So I think, it's not rocket science, right? It's the old thing of knowledge is power. So what we've got to do is be more outspoken, I think, as a profession about explaining the causes of miscarriage, because the vast majority, almost all miscarriages, are completely out of anyone's control, out of the mum's control, out of the dad's control, out of my control as an obstetrician. Most miscarriages are caused by chromosomal abnormality in the pregnancy. So sperm or egg carrying the wrong amount of chromosome information, and as soon as that sperm or egg, which carries the wrong amount of chromosome information, is the one that wins the race to fertilise that baby, the outcome is usually predetermined from that point, and miscarriage is almost always going to be the outcome in that situation. And so it is really important to explain to people that that's, without knowing about a particular pregnancy, that about more than 90% of miscarriages are caused by chromosomal abnormalities in the baby. Okay. And they're things that people have no control over. Okay. So I think getting the word out at a community level, whether that's podcasts, whether that's, social media posts, whether that's discussions in, women's health groups like Mamma Mia and those sorts of, getting that knowledge out there. And I think they're starting to do that, but I think there's always the opportunity to do more.
Yeah. And
Yeah.
I think it's important to discuss that, I don't want to make it about this, but, there are two people who are trying to build a family here in a lot of cases. And one of these people can often feel left behind or feel like they can't speak to their friends about it. And I am talking about potentially the husband or in a same-sex marriage, the other partner who's not carrying the child. What recommendations would you potentially make to help them, accept that they're allowed to be upset as well?
Yeah.
They're allowed to grieve. And what's some advice for that aspect?
Yeah, I think it's a really good point. And it's something we don't actually, as a profession, devote enough time and energy to. I think it's been a neglected area. And it's, again, these things are starting to change, but change is slow and, happens gradually.
Of course.
I think from the moment you get that positive pregnancy test, right, in the bathroom, as a couple, you start to dream, right? You start to think about what you're going to name it, where it's going to go to school, what footy team it's going to barrack for. You can't help but get excited, right, as soon as you find out you're pregnant. And that goes for both partners. And the woman carrying the pregnancy bears the physical responsibility of dealing with that, including going through a process of miscarrying or having a surgical procedure to clear the uterus out once a miscarriage has been diagnosed, whatever. So there is a lot of attention on her, which is quite correct. But I think partners need also to be able to acknowledge their feelings. And one of the issues, I guess, is guys sometimes don't openly acknowledge their feelings to themselves or their friends or whatever. Guys sometimes don't talk about those things. And that's not always a good thing, right? And I think that we need to, when I'm dealing with people in the room, when I'm talking to them about the fact that they're having a miscarriage, I talk to both of them, and I do try and acknowledge those feelings. I encourage them to both talk openly about it with each other, but also with their friends or their family and things like that. And, we hope that that's what happens. But there are lots of support groups around, and sometimes making a step towards a support group is a hard step to make. That's, I think, for both partners in the relationship. But if you certainly if you were to reach out, there are definitely support groups around that can provide you with counselling or just give you the opportunity to talk to other people who've been through the same situation. And often I think that's as important, if not more important, than any sort of formal counselling or anything like that. Most people are very sad, but most people are also able to process miscarriage and are able to think about coming back and trying again. But a smaller group of people get more significant mental health impact from miscarriages, including depression and anxiety and those sorts of things. And certainly when we're seeing those sorts of symptoms, we need to direct people towards more formal care. I always encourage people to look out for each other. So if you see your partner not coping, then you need to talk to them about it, or you need to come and talk to me or to someone else and say, look, he's really struggling, or look, I know she's putting on a brave face, but she's, when she gets home at night, she's just a mess. Those sorts of things. It's about looking out for each other, recognising that you're a couple and a team.
Yeah. I guess it comes, it's funny I'm mentioning it in this episode as well as the last one, the old adage that it takes a village to raise a kid and to raise a family, and that starts before the baby's even born. We've got our friends around us. Let's lean on them. As a young male, I'm going to speak to the audience here. Reach out to your mates, reach out to your friends. If you are going through a tough time, they are there to support you. And I guess that's what the honour that you get being someone's friend, that you get to help them through that difficult time. And I think that reframing is really important and something that, we are discussing more, which is really, really great.
I would just make a comment, though. I think that it's not for everyone. Some people, everyone processes grief and stress differently, right? And for some people, talking about it, particularly talking about it outside that very close couple unit, is actually not helpful and can sometimes cause them to sort of feel more to struggle to process things. Some people do process things internally. And one of the things I've learned over many, many years is we're not all the same. We're not all the same physically and medically, but we're not all the same emotionally as well. And I think it's really important actually for you to think about your own needs. And often your needs will be exactly what you said. Reach out, talk to people. You may not even realise they're your needs, but they usually are your needs. But some people actually handle these things internally and handle them well. And I do think that we have fallen into the trap a little bit of putting everybody in the same boat. That women process miscarriage this way or that way. And in fact, women aren't women. Women are individual people. And as a collective, that's fine to talk about in a generic sense. But as an individual person, we've got to work out what an individual person actually needs.
100%. I'm really glad that you sort of brought that up and created that, I guess, positive association with being able to process things independently and on your own. I think that's a really important point. Moving into a different area of pregnancy, and I guess this is more towards the end of it, we are going to talk about some C-sections. These are becoming more common. I believe 1 in 3.
Yeah, about a third of Australian babies are born by Caesar now, yeah.
Yeah, and it generates a lot of emotion in Australia, and it's a bit of a topic. But, if someone comes to you and says, I want a Caesarean, not for any medical reason, but it's just their preference, what's your approach? How do you have that conversation?
Yep. So I always start by saying, I'm going to support you no matter what you decide.
Incredible.
Okay, that's my first sentence. But then I say to them, but I want to make sure you understand the decision and the pros and cons of the decision, and I want to understand why you're making that decision. Because ultimately, I don't discriminate on a person's choice. I want to be really clear that they're making their choice for reasons of correct information and that they haven't been misinformed by community, social media, friends, whatever. Okay. And so my first step is to explore why they say they want a Caesar, and then to try and, really drill down and work out whether those reasons are not whether I think they're valid reasons or not, but whether I think they're based on correct information. Okay. I think the decision making is valid no matter whether I agree with it or not, but I want it to be based on correct information. Yeah. And sometimes it's things like, I'm worried about pain. Mm-hmm. And I'll actually say to someone, well, in fact, if you're worried about pain, you probably shouldn't have a Caesar, because you'll have more pain with a Caesar after the birth than you will for at least the vast majority of vaginal births. Mm-hmm. And if you're worried about pain in labour, we can talk about putting an epidural in right at the very early stages of your labour, and you can effectively have a pain-free labour. Mm-hmm. So sometimes we come to a point where she says, well, okay, well, that actually makes sense. Maybe I hadn't really been thinking about this the right way. Okay. Yeah. And then if she changes her mind and aims for a vaginal birth and has a positive experience, that's great. And if she says, thanks, but I still want a Caesar, that's also great.
Yeah.
Okay. So, we've also dealing with the other side of the coin, of course, of people who really don't want a Caesar and for whatever reason find themselves in a situation where they're being told that they should have one. Mm-hmm. And then again, we have to bring people on the journey with us. So this is very much about collaborative decision making. So we're really respectful of a woman's right to control her own body and decide what happens to it. Okay, but we still want to give the correct medical advice around risks and outcomes and all of that sort of stuff. And whether a patient chooses to accept that advice and run with having a Caesar, or whether she chooses not to accept that advice and say, well, you may well be that you've said those things, but these are my priorities. Again, that's very much a choice that she's entitled to make. I think what's most important is that it's made collaboratively and it's not told to someone that this is what they are going to do, right? And, one of the things I'm really passionate about is women that have experienced birth trauma. And there's physical trauma, of course, related to childbirth, but there's also a huge amount of emotional trauma that comes under that umbrella of the broader heading of birth trauma. And, from talking to women over many, many years, I guess one of the recurring themes in terms of what contributes to the trauma is the feeling of lack of control, the feeling of lack of being involved in the decision-making process or not being listened to, feeling railroaded and getting an outcome that they didn't expect and didn't want, and hadn't really participated in the decision-making process. And so one of the things that I think we need to do as a profession, midwives and obstetricians, is get much better at actually pulling people along a journey with us, going on a journey with them, maybe is a better way to say it, rather than saying to them, this is what you need to do.
Yeah, I think that's a really good segue into, I guess, one of the most profound things that I've ever heard of, and that is, and this is something that you've done, you're a bit of a pioneer in this, a maternal-assisted caesarean. You can reach down and deliver your own baby during a C-section, and most Australians have never heard of this, but can you explain a little bit more about this? Because this is incredible.
So actually this really arose because of my repeated experiences of women feeling that they'd had a caesarean that they didn't want. They got a birth outcome that has really caused them distress. And so I was very much thinking about how can we make, and many of those women will have to go on and have future Caesars, and they really feel that they've missed out on something that was really special to them, and they'd spent, often a large part of their lives thinking about a vaginal birth. So I wanted to find a way to make a caesarean section something where they could be more engaged. Because traditionally a caesarean section occurs where after a spinal anaesthetic, patient's lying down flat on the bed, there's a screen that goes up so they can't see anything that's going on our side of the screen. And the patient and her husband or partner will sit with each other and talk, and then all of a sudden a baby will appear.
Yeah.
And many women felt very disconnected from that birth. And they're comments that I have heard repeatedly over many, many years. The idea of a maternal-assisted caesarean section is to, is to allow people to have the opportunity to feel more engaged in that birth process and to try and make it a more positive experience for them. And I didn't develop the technique of maternal-assisted caesarean, but I certainly heard about it and thought this is a fantastic thing, and I really wanted to run with it. And we talk it through beforehand, so we make sure that everyone's on the same page, because people will see more of what's going on in the operation because we don't have that screen up that's excluding them, right? It's deliberate, but they have to be prepared for that. So they don't really see a lot of blood or anything because there isn't a lot of blood, certainly in the early stages of the operation. And mums have a big belly that's shielding them because we're operating on the other side of the belly. So it's not quite as scary as people think that it might be, but it's still a bit intimidating. For many people, just being in a theatre environment is intimidating, let alone seeing surgeons doing their work on them or on their partner. Okay, so we talk it all through first and make sure that they're happy, that they're up for that, basically. And then we talk about how it would work. So a patient will, before the operation, will do a scrub like a surgeon would do at the sink before an operation. And then once they'll come into the operating theatre, they'll get their spinal anaesthetic in, so they're getting numb. And when they're lying down on the bed, we'll wash their hands again for them. The theatre staff will help with that. We'll put on a surgical gown and surgical gloves. And then the woman will lie there with her hands, keeping herself sterile. And that's really important because she's putting her hands into an operating field, right?
Yeah.
So we have to make sure that she maintains her sterility in terms of her hands. And then I'll deliver the baby's head. And then we'll tilt the table a bit so that she can see what's going on. I'll guide her hands down. She can touch her baby whilst it's still in her womb and get to know it. And then when she's ready, we'll get her to lift her baby up by putting really hands under the armpits and around the thorax and just lifting the baby up in a big arc so that she can see it, hold it, look at it, and then straight up onto her chest so she can do skin to skin immediately.
That is unbelievable. There's literal tears in my eyes just hearing about that. That's mind-blowing. What's the next steps for something like that? Because obviously she's now on the chest. Are we now at the stage of a normal vaginal birth, or?
Well, we've still got to put everything back together again from the Caesar, right? So we try and do some delayed cord clamping for a minute or so that, and that's really important for healthy babies. And then we cut the cord, and mum and baby can just sit together and cuddle. Paediatrician might want to check the baby out, but not always. And then mum and baby can just stay together with dad as well. while I finish what I need to do. And the rest of the operation usually takes about 20, 25 minutes of putting everything back together. And then the three of them will go together or almost together to the recovery area outside of the operating theatre.
What a journey. Like, that's incredible. Have you found that there's a lot of people who opt in for this when they're given that option?
Yeah, I think there are some people who are intimidated by the thought of seeing more in the operating theatre and who are very intimidated by a theatre environment and who choose not to do it. And I'm really conscious, again, of not railroading people. So I don't force maternal-assisted caesarean sections or I certainly don't want to make people feel that they're being pushed down a certain pathway. So I offer it.
Mm-hmm.
And then we discuss it, and then I'm happy for people to make decisions. And I think about half of people, a third to a half of people who have the discussion decide that they want to do it. But there's still plenty of people who just say, you know what, I don't want to see any of that. Just show me the baby.
I think having that option, though, it's just incredible to give people that opportunity, especially if they were on their journey. They're being told that maybe another step is going to be required, and it gives them that opportunity to still be literally hands-on and involved in that. So,
and I think the people who really cherish it, in particular, I think everyone who I've done a maternal-assisted caesarean with has found it an incredibly positive and enjoyable experience. And even people who were nervous about it but who decided they wanted to do it, their nerves just disappear as soon as they see and touch their baby, right? And and everyone has loved it. But I think the people that really benefit the most from it are people who missed out on a certain element of the birth that they had last time.
Yeah.
So they were desperately hoping for a vaginal birth, got rushed in for an emergency Caesar, didn't get the image of birth that they had fixed in their mind, and they've carried that baggage with them, for a year or 2 years or whatever until they have their next birth. And when those people have the opportunity to do a maternal-assisted caesarean, you said tears in your eyes. I've cried in maternal-assisted caesareans because you just see the joy in you see the raw emotion, right? One of the things about obstetrics that I love, but which can be overwhelming at times, is the absolute raw emotion sometimes. It can be, it's good most of the time. It can be bad sometimes as well, of course, because outcomes aren't always good. But that raw emotion of someone who gets to deliver her baby by caesarean section herself is quite spectacular.
Yeah, and I think that positive note is a really good way for us to wrap things up today. Thank you so much for such a rich and insightful conversation. Thank you for your time today and the work that you're doing to support Australian families. If this episode has supported you through a journey or has given you some insight in something that your friends might benefit with, please feel free to share it. Once again, thank you for joining us on the Patient in the Room podcast with Dr. Fi, and we'll see you guys next time.
Thank you for inviting me.
Pleasure.